our next speaker then is Cristina Lecerda, and Cristina is a member of the EONS board, and she's going to speak about chemotherapy and extravasation. So thank you, Cristina.
Good morning, everyone. I hope you enjoy this presentation. If you have any doubt, you put your hand out and I can explain to you everything, okay? During this presentation, we're going to review and update the knowledge about chemotherapy extravasation. We're going to identify the risk of chemotherapy extravasation and act according to best practice to prevention and management in chemotherapy extravasation. So, what is extravasation of chemotherapy? We have a lot of different kinds of definitions. This is one. Is defined as an accidental infiltration of chemotherapy into the subcutaneous subdermal tissue at the injection site and can result in tissue necrosis. I show you two different kinds of necrosis here. And this is from a central venous catheter because some people think because the patient have a central venous catheter do not have an extravasation, and that could occur also. And this one is from the peripheral venous catheter, okay? These pictures, I take them from the internet. They are not real patients, but they are very illustrated. That's why I put it here. Chemotherapy administration carries safety concerns, which includes accidental extravasation to patients and remains an accidental complication of chemotherapy administration and may result in serious damage to patients. Here you can see we do 1 million infusions each day worldwide to give chemotherapy. I didn't know this number is so big. And the percentage of the chemoextravasation still has prevalence and range for 0.1 to 6% to the peripheral intravenous access and 0.26% to 4.7% at the central venous access device. So, what are the risk factors concerning to this? These are the potential properties of the chemotherapy agents, patients, factors, and iatrogenic causes, like have well-trained nurses, for instance. Related to the chemotherapy agent, vesicant properties to drug, its concentration, volume, and duration in which the infusion is extravasated, they are the things that are important when this happens. Related to the patient factors is age, that is not here, small or fragile veins, lymphedema, obesity, because an obese person is more difficult to have a venous punction, impaired level of consciousness, and having a previous multi-vein punctures. Iatrogenic causes is lack of training of nurses, poor cannula size selection, poor localization selection, and lack of time. These are other causes that could cause extravasation. And this is going to be this lodgement of the distal tip of the cannula into the tissues surrounding the vein, constricting the blood flow distal to the cannula tip, which increases venous pressure and allows the fluid to leak to the hole in the vein made by the cannula. Inappropriate selection of the position and size of cannula and the length of time which the cannula is left in the situ. Practitioner and familiarity with the drug and the manufacturer's recommendations for administration. And we have a lot of new drugs every year. So we must know how the anti-cancer drugs are classified. We have the vesicants, the exfoliants, the inflammatories, irritants, and neutrals. And this classification is based on the potential of damage of the tissue. These are some examples of vesicant drugs, exfoliants, irritants, inflammants, and neutral. Vesicants are drugs that can result in tissue necrosis or formations of blisters when the accidental infuse into the tissue surrounding a vein. They include actinomycin D, dactomycin, daunorubicin, doxorubicin, epirubicin, mitomycin C, vinblastine, vindizine, vincristine, and vinorelbine. Maybe you know these drugs. They are very well known, and we give them everywhere. Exfoliant may have low vesicant potential, and they are drugs that can cause inflammation and shedding, peeling off of the skin without causing underlying tissue death. Drugs may cause superficial tissue injury, blisters, and desquamation. They include diomycin, cisplatin, docetaxel, doxorubicin, metoxantrone, oxaliplatin, and paclitaxel. These are very well-known drugs also. Irritants, they are drugs that can cause inflammation, pain, or irritation at the extravasation site without any blister formation. Clinic use the term irritants also to refer to drugs that can cause burning sensation in the vein while being administered. So we have some examples like bleomycin, carboplatin, ectoposide, and topotecan. Inflammants, they are drugs that can cause mild to moderate inflammation, painless skin erythema, and elevation. And these are called through reaction at the extravasation site. They include bortezomib. Bortezomib could be given IV or subcutaneous. In our days, the more often we give subcutaneous, not IV. But in the beginning of giving bortezomib, we give it IV. 5-fluorouracil, methotrexate, and the other one. Neutrals, they are drugs that neither cause inflammation or damage up until the extravasation. Usually they are monoclonal antidotes like rituximab and trastuzumab, and are also listed under this category: asparaginase, bevacizumab, bleomycin, bortezomib, cetuximab, gemcitabine. And you can ask me, I have the same drug in two different kinds of classifications, and some drugs could be classified as one or another, and that depends of volume there is extravasate, and the concentration of the drug, and the time that extravasation occur, and you don't notice there is extravasation. So these classifications could be different because of this. This is just for be more. You can see here easily all the drugs. But we have other reactions that they are not extravasation, and sometimes people mistake with this. And it is the flare reactions, and you see here, this picture is very good because you see all the trajectory of the vein become red during the infusion, but these go away 1 or 2 hours after you stop the infusion. And you could have a vessel irritation that's different, or a venous shock. So the flare reaction may occur with anthracycline administration. Is a transition painless skin striking erythema looking like urticaria with skin elevation. If you are young and you never see that, it's very scaring. But after a while you recognize it, so it's very easy to recognize. It is usually associated with itching, burning sensation and pain, but it's resolved in 1 or 2 hours, and blood return is on the infusion site. Vessel irritations cause pain, discomfort, and tightness along the infusion vessel, with possible accompaniment with erythema and dark skin discoloration. Presence of blood return at infusion site is present, while both flareation and vessel irritation do not usually present with erythema. The extravasation is usually associated with swelling of tissue surrounding the infusion vein and predominant manifest by erythema. Venous shock is due to the administration of very cold agents because people are waiting for a long time, they come from the pharmacy, and we want to infuse immediately, and sometimes it's very cold. And this cause, the vein is causing the loss of blood return due to a venous muscle spasm because the temperature is very cold, and it's managed by application of warm compresses, which can calm and to relax the vein. This is very discomfortable to the patient. So, how can we prevent extravasation? This is the important of this, is education all the health team. And the health team is doctors, nurses, and clinical pharmacists. For nurses, we must be sure about the vascular access, cannula, and needle selection, and empower the patient and their families also if they stay there. Educating is needed to they understand the manufactions, and they have cooperate with us and tell us if they do not feel well in any sense. Oh. Okay. It's okay. So how can I choose the right venous access device? We have a guide that could help us. If the patients do not have vesicants or irritants, chemotherapy medications, you can do it by the peripheral venous access. If they have a vesicant, you should prefer use a central venous catheter access. And this is the way how you can choose, and everyone should do the choosing at the same way. Have the same things on concern when I do it from the peripheral or for the central venous. Sometimes we choose peripheral, and when the patient is sitting in front of us, we should choose another site. Why? Because patients are dynamics, and from a cycle from another, they are not exactly at same. And if something is changing, you need to assess and change it too. And no problem of doing that, okay? So, what do we do when we have an extravasation? We must stop, and this is very important. Do not remove the cannula. Disconnect the infusion. Leave the cannula needle in place and try to aspirate as much drug as possible. Collect the extravasation kit, cold or warm compress. Make the affected areas and take digital image. In our days, it's very easy, but when I began 30 years ago, it's not so easy. Remove the cannula. Check with the category drugs belongs. To if the extravasation is with anthracycline, use dexazoxan, Savan. I'm sorry, I put Savan because it's more easy to say. And it's the only antidote to this kind of drugs. And if they are vesicant but not anthracycline, needs to immediate refer to plastic surgeon for potential formal of subcutaneous wash-up tissues. Administrate pain relief as required and decide on appropriate damage limitation management. Here we have colors, and I think this is very good because with these colors and all the drugs, you can see when you should put cold compress or hot compress. So it's very easy to use and it's very visual, so everyone could know what to choose. And sometimes must be very fast. So you need to do it in the fast way. And you need to have a kit of extravasations. They are already built in the market, but for instance, in my country, and I come from a poor country, we build our own kit of extravasation. You don't use this one. I know a lot of countries have this one in every places, but in my country, we have built our own kit of extravasation, and we have it every place that we give chemotherapy. You must do the report. This is how you do the screening of the skin damage and the importance of the safety communications is here too. You, doctors, and everyone of the team must speak the same language. So when you assess for the skin damage, you must all use the tools that we have, and if you say it's type 2, you know what grade 2 means. And if you say it's grade 3, you know what grade 3 means. And the doctors know that, and everyone must know that. So these are some examples of antidotes. This is for anthracyclines. This is for alkaloid fincos. I think maybe you have all of these. I'm not certain. This one is very expensive. So in my country, in my hospital, we have one in the pharmacy, and all the service they need it, they must ask to the pharmacy for this. We don't have one in each unit. The others we have, but this one, no, because it's very expensive. So, how can we treat the wound? By surgery and the negative pressure or hyperbaric oxygen therapies. They are on research, but they could prove to have a good end for this kind of things. And when I have done this presentation for the first time, someone tell me what is the impact of chemotherapy extravasation on nurses. And I didn't put in my first time, but I'm putting now. because when a nurse have an extravasation, and I went to the literature because we don't have a lot of research done on this subject. I just find one research paper, and it was in Netherlands in 3 kind of different hospitals, and they say they should previous studies. The majority define an extravasation as a serious incident. The risk of extravasation both influencing the decisions with regard to inserting and checking IV catheter. The emotional reaction after extravasation mostly consists in getting startled and become stressed out. What this means is we are insecure when you go again and do all the things. Support by co-workers after is important to decrease the effect of the extravasation on nurse. We always think about patient, and the patient, of course, is the most important, but nurses, they are important too, and they must go on to doing that. And they must understand what's happened, because otherwise it's going to be very difficult for them to go on. So this is the message that I want to give you. It's about education the patient and health team, prevention and management of extravasation, follow-up, and articulation with multidisciplinary team. Thank you.
Thank you, Christina. That was really informative and really useful for practice, I think. Have we got any questions? Are there any questions? Okay. Christina, we've got a mic, just a second. Could you say who you are, where you're from?
Yes, I'm Kristi Rannus from North Estonia Medical Center. I'm a head nurse of the oncology clinic. And yes, we have those extravasations. And my question is about those what reveal later. They go home, they have no problems, and then they come to check out, and they have burned marks in wrist. Can we prevent those somehow?
What we do in my country, we monitoring the people who go home by phone. And if something is happening that is not normal to happen, they should come and visit us. And usually between the time of the consultations, they always monitoring them by phone. We give them the instructions. We tell them to wash for the site, and after we check with them during a week, most of them. And something is not well, if they have more pain, if they are more red, yes, they should come back to our hospital to be seen by a nurse and after by a doctor if it is needed. Yeah.
Any other questions? No? Oh, yeah. Okay. Lemmonly?
Hello, my name is Lemmelis. I'm from Tartu University Hospital. I have a question. If an inpatient has an extravasation in the end of the chemotherapy, do you monitor them longer in the hospital, or do you send them home with just some instructions?
We usually have this sheet that I have where we put everything, and the patient is monitored by the nurse of the consultation, outpatient clinic, not inpatient, and they do not stay more because of that. We do all the teaching that we must do. The doctors see the patients also, and after they go to the consultation and they go home. Yes.
Yeah. Certainly in some hospitals, just thinking on from what Christina's talking about, in some hospitals now they have IV teams. So teams that literally, that's what they do all day long, is go around and put in cannulas, look at sites, look at the sites of the chemotherapy nurses that have inserted cannulas, and just check constantly on the infusions and on how they're progressing. They also are available to put in the central venous lines, so that it makes it much more easy in a way to decide on a central venous line. I think in the past what's happened, certainly in the UK, I don't know about the other countries, is that nurses, chemotherapy nurses, have been reluctant to have a central venous line if it means they've got to wait for a doctor to insert that line. So now with IV teams, and certainly in the UK, we tend to have one in most of the hospitals, certainly the big cancer centres, because it just makes it much easier. What about in Portugal?
Yeah.
Do you?
In Portugal, it's the doctors who put the central venous catheter. We do the assessment of the veins. If before they come to the chemotherapy, if we think the patients need venous catheters, they must put venous catheters before he comes to the chemotherapy unit. And the peripheral venous catheter is put by all nurses. In my country, we don't have IV teams.
No.
Yeah.
Okay. Thank you very much.